Welcome to The Scope with Dr. K, where together we can reimagine GI care.
Welcome to The Scope with Dr. K. I'm Dr. Kosinski. We're going to open the show today, as we always do, by stating that the goal of the series is to present you with a broad scope of value-based care issues, mainly involving, in some way, the field of gastroenterology, but also outside of GI as well. In today's episode, we are continuing with our current series focused on value-based care solely from the view of the health plan. We always refer to our universe of value-based care as the world of the 4 Ps: patients, providers, plans, and payers. The health plan is at the center of these Ps and interacts separately with each of the other 3 of the 4 Ps: self-funded payers, providers, and patients. Therefore, it's very important that the others understand the goals and needs of the health plan. To continue this series, we have chosen Dr. Amy McKenzie, the Associate Chief Medical Officer and Vice President of Clinical Partnerships at Blue Cross Blue Shield of Michigan. In her current role, Dr. McKenzie and her team provide clinical leadership for value-based provider programs and risk contracting. She helps to enable and support the provider network through education, communication, and practice transformation partnerships. She also leads the team responsible for enterprise-wide behavioral health strategy. Welcome to the show, Amy.
Thank you. It's great to be here.
Oh, I look forward to it. We're going to have a great discussion this morning. How would you describe the view of value-based care from the position of the health plan?
Yeah, so when I look at value-based care, it really is an approach to align the core tenets of what's been described as the quadruple aim to the way that healthcare is paid for. So, delivering higher value in healthcare was initially described, as many of you know, as the triple aim, right, where we're focusing on population health, improving quality for populations, improving patient experience, and managing cost. Over time, in looking at different things, I think people became aware that you also need to manage the provider satisfaction in that relationship in order to get all of those things to work. So, if you have a provider that is overburdened, burned out, they're not going to be managing their patients as well either. So it's really aligning how we pay for healthcare with trying to deliver all of those things, which is something that, we as a health plan are interested in, but so are our customer groups and, us as patients, right, who are navigating the healthcare system. We want to have a good experience. We want to have high quality care. Those are the common things that I get asked when people are looking for, where do I go? Who should I go to? Who's going to give me the best care in the system? Those are the types of things that people are looking for. But we also want to make sure that we're keeping care affordable, right? I think about my kids and my grandkids, and we all have to be able to afford the health care that's being delivered as well. So that's why all those core tenets are kind of stacked up the way that they are.
So what are your biggest challenges? What keeps you up at night in your role?
Yeah, so I think the big challenges are really as we try to think about how we put this model together, right? The evolution of the model. There's been a number of different ways that, our payment models have evolved, from fee for service to how we pay for higher value with incentives to, capitated payments where you kind of give a lump sum to certain groups. But as you start looking at this as a system, we have to think about how we tie all of those pieces together so everybody has the right incentives to be able to perform, but then also be rewarded appropriately for the high quality care. That's what we want for our providers, to have the right incentives so that it's not just feeling like it's reporting, but that they're being able to be measured and tied into, delivering the best care and then being rewarded for that. And that becomes complicated when you start looking at, you have payments going on at the ACOs, and then we also have specialists to think about. Like primary care is very important, right? We know that there's significant studies out there that primary care, adds value and adds, longevity to populations. And so we know that model is important. But increasingly, as we are getting, we're having a population that ages, that has more chronic conditions, and are interfacing with specialists more. How do we also then develop models of care as well as payment models that are aligned to that to make sure that our specialists are being appropriately recognized and rewarded and pulled into that system and working collaboratively with our PCPs. That's really what we want. And that's where the kind of nirvana, I guess, sits, right? Is that interaction, because things that drive, frustration for patients are when their path is not linear, right, through the system. Go over here, then go there, and, or they have fragmentation, right? I just had that x-ray and now I'm repeating the same x-ray because I'm seeing a different specialist and they don't have access to my services or to the prior results that happen. So being able to tie that so that everybody has kind of the right incentives, and also communication and reducing fragmentation is really important. The idea, and I think, you and I talked a little bit before about this, is, the goal for patients is to have the most linear path through their care journey to be able to get the care that they need and feel better. That's what all of us want, right? And so we are aligned with that and looking for that as well. So it's challenging to set up all of those systems that interact, but I do think it's feasible. We're working toward that, and requires, again, listening to our providers, understanding where they're seeing there are things that we can do differently, and this is how we incentivize better the work that we're doing and measure it. So we feel very strongly here at Blue Cross that the only way that we're going to solve these issues is in partnership with our providers. I don't think you can do it any other way.
We talk about primary care, specialty care, but we probably should be talking about total care for the patient, and then based upon the patient's specific illness profile, which part gets taken care of by the primary care, which part gets taken care of by the specialist, and which part should be. And it's so hard to get those incentives aligned so that we're actually paying people for the ultimate total care outcome. Okay, enough about challenges. What have been your biggest success stories? Time to boast.
Yeah. So I would say that our biggest successes, we've had a number of them. We've been partnered on this kind of value-based journey for a number of years with our providers. It started with our kind of patient-centered medical home with our PCPs, but also in conjunction with that, we've partnered heavily with our specialists on our collaborative quality initiatives, which are groups of like-minded specialists who are working on challenging issues for their particular specialty. So we have a collaborative quality initiative that's focused on, cardiac care and cardiac casts and angioplasties. We have one that's focused on surgery. We have one that's focused on bariatric surgery. We have close to 20 now, when you all told, of different CQIs that are focusing on specialty care that our patients are receiving. Increasingly, we're starting to branch into those specialists that are also delivering more longitudinal care. So you think about like diabetes and endocrinologists and, COPD, and pulling in our pulmonologists. Because there's different types of specialty care, right? There's those that are more discrete episodes that, we've seen some evolution of payment models that are out there, bundled type payments and things that are pulling in value. And there's also these more that are interfacing in the longitudinal way. So I would say that, those are big successes for us, in terms of partnership with our providers and being able to measure the quality. And we're now starting to reward our specialists based upon the quality of things that we can't measure through claims, frankly. So those are big kind of foundational programs that have been very successful. Building upon that, we've stood up a bundled payment program with our orthopedic providers. We're having conversations with additional specialists around how we build kind of future payment models that, again, ties to the care that they are delivering and when they're best positioned to be able to take care of that patient for that particular episode. We also have, as you mentioned, I heard you mention a little earlier, those total cost of care programs. Those are really important to consider as well. And we have our Blueprint for Affordability program, which is basically a ACO-like model. So it's at our risk entity level. It's managing total cost of care. And so, We don't have all the pieces solved yet, but we are working toward that. And it's, a key part of that, as I've mentioned, is the partnership with our providers. We couldn't do this without our physicians in our community helping to provide that leadership and also that input into how we build these models.
A spin-off question from your total cost of care models. Out of curiosity, does that include pharma?
Ours do include pharmacy, Medicaid, pharmaceuticals. So it's, there are definitely challenges when you pull in pharmacy as well. But we are working to be able to provide insights. There are ways through that, and there are still opportunities to be able to help manage pharmacy cost. When you start looking at what our employer groups care about, as you outlined the 4 Ps, right? They're looking at the end of the day at what their total cost is. And that's why we felt pharmacy was important to incorporate. It's, at the end of the day, we as physicians have the power of the pen, so we do have influence. We know that there are certain things that, may sit outside of our control, but we do have a significant impact on the overall cost based upon what we are recommending for our patients, where we're recommending their care, ensuring that, trying to get patients to, you hear this, it's kind of a cliche term almost, but the right care at the right time in the right location, right? Selecting those patients. We know some patients are going to be more complicated and going to need more, like when they have a surgery, more of an inpatient setting. There are many that have lower risk profiles, and that, ambulatory surgical centers or outpatient facilities may be very good for them to be able to have their procedures in a lower cost setting.
The pharmaceutical piece is really interesting to me because, I always bring things back to a GI point of view whenever I can. Some of our biologics are on the medical claims, whereas others are on the PBM side, on the pharma side. And using what you just said, the right drug for the right patient at the right time for the right reason. If I'm in a total cost of care model that doesn't include pharma, I could take that patient off the infused biologic that's on the medical claims and put that patient on a self-administered one, and I look really good.
Yeah.
Is it the right thing for the patient though? Is that really the right thing at the right time? So, the PBMs are just looking at it. Maybe that's another P, or maybe that's a 5th P, but they're looking at it just from their book of business and saying, well, we'd rather you put that patient on the infused side because that gets it off their book of business. So I applaud you on a true total cost of care solution, because that really is the way it has to be.
Yeah, if you're not looking at total cost of care, you are missing that overall picture, right? Just sliding things between different benefit structures isn't really getting at the intent of, managing cost.
So if you were if you had your own choice about everything, okay, and you were going to design what you consider to be the ideal value-based proposal for your plan, what would it look like?
Yeah, so I'm going to come back to kind of some of the themes that I outlined. And, as we were talking about that, the first question that you had is really, to me, the ideal value-based model of care is one that is engaging, both our specialists and our PCPs along that patient's entire journey. And then being able to attribute care in a way of who is best positioned to care for that patient during a particular time. Like, I think, I'm on primary care, for my life, that's I was family physician. And so, there are certain time periods in a patient's life where, their cancer treatment, for example, like the oncologist is largely managing the primary care for that patient during those episodes. End-stage renal disease is another great example, right? It's the nephrologist who largely is taking over. And so, when you're setting up kind of an overall value-based care model, you want to ensure that, the person who's primary is the one that is really mostly tied to that total cost of care, because they're the ones that is largely managing that. But you then also have to think about, well, how do you fit in the episodic pieces, right? The times where the patient has to go have their hip replaced or their knee replaced in that overall total cost of care system. And so fitting those pieces together in the ideal model, and in that ideal model, you're incentivizing the highest patient quality, right? It's not suffering for cost. We know that, high quality and cost, they shouldn't be, in two separate conversations as if they are distinct. High quality care promotes cost effectiveness. We know that as clinicians, right? It's all part of what we learned and what we trained on. So there are certainly decisions that you can make within that. We talked about some of those appropriate decisions around site of care and those types of things, but ensuring that our patients are getting high quality care and that they're having a good experience is all part of that. And also in a system where we are more tightly partnered and we have the right incentives, being able to take off some of the constraints that get in the way, the administrative things that we know are really challenging for our providers. I think in that world where we're able to, enter into those kind of shared risk type of models, there's that place that exists where we can start saying, well, we're not going to apply all of the same levels of oversight that we did, right? Or we're going to turn that oversight over and then you report back to us on kind of how you're managing those types of things. So it becomes that more deeply partnered relationship that I talked about at the beginning.
A lot of things become possible when we're in a risk environment. That's definitely the case. I'm going to break here for a second. If you've just tuned in, you're listening to The Scope with Dr. K. Our guest today is Dr. Amy McKenzie, Associate Chief Medical Officer at Blue Cross Blue Shield of Michigan. Amy, I'm going to switch our focus a little bit here, and it's appropriate based upon our earlier discussion. You mentioned places where Blue Cross of Michigan has had its focus. At Sonar, we often hear that GI is not our focus this year. How does the plan decide what is in focus?
Yeah. So just like, every system, health systems, hospitals, facilities, we are looking at, a number of things that we have to address. And as we move into specialty care, there's a lot of opportunities in that space of things that we need to build. I do think GI is one of those very important areas. We know that, inflammatory bowel disease, as you mentioned, it's a significant area where there is that longitudinal management and there's opportunities around that. So it's more about, how do we prioritize the work based upon kind of what we need to do. We're still building out oncology models of care that will fit within kind of that overall total cost of care construct, which we just launched, 2 years ago. And so we are increasingly stepping into that specialist space and going, okay, what models of care and what payment models tied to those models of care are going to make sense. So it's going to take us, a little while, but we are committed that this is a really important portion of the work that we are doing and that we're going to be doing as the population ages and we're seeing increases in chronic disease. So I wouldn't say that any one specialty more or less important. They are all important. They're all like our patients are interfacing with all of our specialists. It really is just like, how do we prioritize like the things that, as we move through those models? We also have our CQIs, as I mentioned. We're continuing to look at how we tie value because we do feel like, what we've seen is we are able to get better quality measures there than just about anywhere. We've looked at claims and, we can measure certain things, your utilization within emergency departments or inpatient, and that all is important. But understanding like, what's your complication rates? What's your, level of transfusion rates with a particular, procedure? Your infections following procedures. That's all information that we've been able to get more through our collaborative quality initiatives, where we're able to get more granular data. So we're continuing to push into that space as well and tie value-based measures into that space. So that's work that we are doing across the existing CQIs, and we're looking at where we can continue to build opportunities. And I think GI is an important area.
Where do you see ACOs fitting into your strategy? How do you see them fitting in?
Yeah, we do think that ACOs play an important role. They're probably not the only role, right? Because we still have people who are living in rural areas. who are more outlying, that we're going to have to think about what other models make sense. We do watch what CMMI is doing closely with CMS and weigh in. We think that there are opportunities for additional model growth. Palliative care is one area heavily underutilized in our country, right? And so those are areas where we think that there's continued opportunities for growth as well. But we do think that the ACO model is an important model, but it's not the only important model. And, this idea of what other models need to be in place to drive, because just putting out total cost of care without thinking about what the underlying care model is going to look like to be able to drive that, it's not going to be successful. So you have to start thinking about all of the components within a healthcare system and the things that are needed and the tools that physicians need in order to be able to drive toward addressing cost while not compromising quality and also providing for that patient experience. So we're very supportive of the continued evolution of those models. I also will say, putting on kind of both my payer but a little more my provider hat, providers can't deal with a bunch of different models from all over the place, right? This healthcare plan is doing this and this one's doing that. We are very much a proponent of having multi-payer models that make sense, because, I don't have time when I'm in the office to look up, is this the Blue Cross model? Is this the, Cigna model? Is this the, being able to do care in the way that we deliver care for patients, we deliver care for patients, right? So you don't want to have it's just impossible to manage the logistics of having one care model for a particular group. So we're very much a proponent of where we can tie in with CMS and other payers to be able to help promote care models. We're very much a proponent of that as well.
Well, again, I'm very pleased to hear your answer to that question. So am I reading you correctly? You sort of feel there should be some skeletal infrastructure to an ACO that over and above the health plan just turning over responsibility to that ACO, you owe a responsibility to your members that ACO has some value-based skeletal infrastructure that not guarantees, but promotes the right outcome for you.
Absolutely. Every one of our contracts, when we are looking at, ACO type models, has components embedded in there around expectations of delivery of quality, as well as delivery on patient experience. Those are important components as we look at partnering with our providers in risk, because we are not just after, cost at all costs. We are after, trying to drive better quality and patient experience, and knowing that when we are doing the right things, that results in a better overall control of the member's condition. So thinking about how do we get care upstream? How do we get the right resources to the right patients? Having the data to be able to stratify patients by their risk and then apply the appropriate care models to those patients. So all of those things are part of taking risk and have to be built into that overall care model to be successful. At the end of the day, it's taking care of patients, right?
Absolutely. My final big category of questions here is going to surround point solutions. You and I have both participated in the Blue Venture Medical Advisory Board, and we see these solutions coming in, and I'm sure in your position at Blue Cross of Michigan, you must be getting inundated with point solutions. Someone comes in, they've got a solution for this small component of the entire value chain. And through the COVID experience, virtualization has occurred. Mm-hmm. And now we're seeing companies come in and disintermediate the doctor-patient relationship using a technology or some type of a point solution. So how do you approach this? How do you approach these small point solutions?
This is a challenging one, because there are definitely things that are coming into the market that I think are going to, enhance the way that we take care of patients, right? Provide some of those tools that we just talked about that are needed. But we are looking at it in a way of how do we do it in a partnered way with our existing provider community? I think about like remote patient monitoring. That's a great evolution. It's going to be able to help patients to better understand their blood sugar and share that with providers. It helps our, providers to better be able to manage things like congestive heart failure or, COPD and keep people out of the hospital. So those tools that are coming in that are being developed as part of these point solutions, we see as tremendous value. Figuring out how you get it into the overall care continuum in a way that is promoting, kind of that, again, promoting the best care possible, but not disintermediating the relationships that exist, I think is the challenge, right? That we exist, that exists within our marketplace right now. So there are definitely point solutions that we think are of value. And when I say point solutions, I should say technologies and things that are coming as part of those point solutions, but we are still trying to think about that overall patient-provider relationship at the end of the day, and keeping the patient at the center, I think is really core to that.
Well, I'm totally in agreement with you. The challenge is to not disintermediate that doctor-patient relationship, because I think the patient suffers in the process.
Yeah.
We have to figure out how to balance the needs for patients to get care where they're in control of their own future, and yet still maintain them in a care solution with their provider. Amy, thank you so much. You've really shown that the solution is to collaborate and to partner with each other. What's the saying? If you want to go fast, go alone. If you want to go far, go together. So I think you certainly have made that very clear to us. Thank you for being on the show today.
Thank you.
Well, for our audience, thank you for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com, and lend your voice to the conversation on Twitter at HCNowRadio. Be sure to follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine GI care. Until next time, I'm Dr. K. Stay well.
Thanks for listening. I'm Dr. K. Tune in with me next time to reimagine the scope of GI care. If we build it, they will join.